Hey everyone, my name is Effie Hapsha. I am a prosthodontist practicing in Toronto, Canada, and I'm also the founder of Women in Dentistry. Today we are very excited to welcome you to our webinar presented by Dr. Reena Talwar. Now, Women in Dentistry was a group that was founded over 10 years ago. It was founded by women for women. And our mission with Women in Dentistry is to connect, empower, and educate women in the dental field. We hold annual educational events that are known for their academic excellence. But beyond that, as you can see from the photographs on the slides, they're known for the camaraderie and the network and connection between the attendees. So we encourage you and urge you to join us at one of our live events, which will hopefully come sooner rather than later. But in the meanwhile, you can find us online. We have a website, as you can see, womensdentistry.com. And since the global pandemic, we have launched into our webinar format, and we have included in our event section on the website, a webinar section. So if you peruse the event section, you can see the webinars that we have available to us, and you can subscribe to our community by clicking on the blue button that you can see on the screen over there that's called subscribe. You can also follow us on social media. So if you want to take out your phones right now, follow us on Instagram, at Women's Dentistry, like us or follow us on Facebook as well. That's a great way for us to stay connected throughout the year, and we disseminate a lot of information about events and upcoming initiatives through our social media platforms. So without further ado, today's program is presented by the very talented Dr. Reena Talwar. Before we present Dr. Talwar's program, I'd like to go through a few housekeeping issues. This is a webinar, so your audio and video is disabled. I should say your microphones, but there is a question and answer button in the bottom of your screen, so you can certainly ask questions as we go. Dr. Talwar's program is previously recorded, but she is with us live today, so she will be here to answer all of our Q&A. And that will, I think you'll really enjoy the program. So without further ado, I'm going to introduce Dr. Talwar. Dr. Talwar is a dual degree certified specialist in oral and maxillofacial surgery and a PhD in biomedical science. She has been an assistant professor at the University of Kentucky, University of Toronto, and associate clinical professor in the School of Dentistry at the University of Alberta for almost 10 years. She's the owner of Contours Oral Surgery, which is an accredited non-hospital surgical facility and a teaching facility located in Edmonton, Alberta. Today, Dr. Talwar will be talking to us about prevention planning and complication management for dental implants. Welcome, Dr. Talwar, and we will see you at the Q&A section of the program. Thank you.
Well, good morning, everyone. So today I have the pleasure of speaking to all of you regarding prevention planning and complication management for dental implants. Start with a lecture. So some of the objectives here for the webinar would be to review, obviously, some pertinent preoperative steps in successful implant treatment, to review some basic anatomy. You can't do surgery, perform surgery well if you don't know anatomy. So we'll focus on the maxillomandibular complex. Understanding prosthetic options. Even as an oral surgeon, I do focus my conversations with people with regards to implant treatment on the prosthetic option that's been selected first, and then progress to whatever the anatomical limitations are existing and how we can correct them surgically, if we can correct them surgically, and then towards, of course, implant treatment planning based on the prosthetic options. And then, of course, surgical options for salvaging versus removal and replacement of failing dental implants is what we're going to talk about throughout. A little bit of literature. So these articles are from the compendium in continuing education in dentistry. This is a 2014 article, and what I like about these next few articles that I'm going to show you is just the emphasis on team approach. So long-term success of dental implants is linked to well-trained implant surgeons, whether it's general practitioners with advanced training, obviously periodontists and oral maxillofacial surgeons, and restorative dentists. General dentists are challenged to identify early in the diagnosis patients who are at greater risk of developing complications and partner with specialists in formulating treatment plans. And that's the best way. So a couple of just basic definitions, things that we have to address when we're dealing with complications. We want to try to reach the patient and deal with the complications as they initiate, so early intervention, and that would be with peri-mucositis. So the definition, I'm not one to read slides, but these definitions I will. So the presence of inflammation in the soft tissues surrounding dental implants without signs of any loss of supportive or supporting bone. Basically equivalent to gingivitis. So we want to be able to see these patients during the peri-mucositis stage of potential complications and not later when they're in peri-implantitis, where we've got now a destructive inflammatory process. The same array of periodontal pathogens are found in the oral cavity in periodontal disease as they are around failing implants. So when we get to this point, we're really dealing with a much more complex scenario and a lot more surgical intervention, which may not be predictable. So some anatomical considerations, like I mentioned, you can't do surgery without having good knowledge of anatomy. And of course, when it comes to implant planning, we have to consider all of these things. So the skeletal relationship. Obviously, we know that when a patient loses their teeth and the length of time between tooth loss and the time that we see them, and they're in removable prosthetics, we're going to advance from maybe a mild to moderate volume of bone loss to severe bone loss. And trying to gain a vertical bone height in moderate and severe atrophic maxillas and mandibles is one of the most challenging surgical procedures to do. We can indirectly gain vertical height in the maxilla posteriorly by elevating the sinus floor and doing sinus lift procedures. However, vertical bone height gain in the mandible, especially posterior mandible, is very difficult, and it's been attempted in many ways. Interarch distance, of course, all of that would increase with increased time and post-loss of dentition and wearing of removable prosthetics. Super-erupted opposing dentition, that needs to be addressed, focusing on the tooth loss site and not thinking about the opposing occlusion and how it's going to affect will really lead to a disastrous treatment planning scenario for patients, because now they're going to be surprised with additional costs that they weren't thinking about when they came in, because if we didn't or you didn't address them. The mesiodistal width of the edentulous space, so having tipped teeth into prolonged edentulous or partially edentulous sites, those need to also be addressed with the patient. So are they going to need root canal treatment? Do they need some contouring only of the tooth, or is it going to be root canal with crowns? Things like that. Again, added costs need to be discussed. Obviously, the buccolingual or buccopalatal width, if you think about a standard implant being approximately 4.3 millimeters in diameter, you want to have at least 1 millimeter to 1.5 millimeters buccally and lingually. The thinner the cortex, especially on the buccal, the increased risk of post-implant insertion, bone remodeling, thinning, and potential exposure of the implant itself through the bone, or shadowing, especially in the aesthetic zone, and then combine that with a poor soft tissue biotype and you have a disastrous result. So you want to be as ideal in your positioning and maybe use angled screw channel type prosthetic abutments to correct some angling that you would have to do for implant placement in order to get a screwed in final prosthetic. I'm a big fan of screwed in prosthetics, although I don't do prosthetics. Vertical height of the edentulous space, so relative to the natural dentition, relative to vital structures like the sinus floor, the nerve canal, mental foramen, and fossas, concavities on the lingual aspect of the mandible, like the sublingual fossa, submandibular fossa. And I'll show you those in some upcoming slides. Other anatomical considerations would be the maxillary sinus floor anterior wall position. So we all know that generally the maxillary sinus floor is apical to the maxillary premolar, molar dentition. It varies among individuals. It varies within individuals. One side could be more pneumatized than the other. The anterior wall may be more anteriorly positioned on the right maxilla versus the left, or vice versa. So all of those have to be taken into consideration. Just as an aside, when I'm looking at patients who are, or treating patients who are fully edentulous or soon to be fully edentulous, and I'm planning all-on-4 maxillary procedures, I use the anterior wall of the maxillary sinus as my guideline for the most distal angled implant, and often try to engage that posterior wall, the anterior wall of the maxillary sinus and the posterior wall of the implant to get some cortical stability with implant placement so that I can achieve that ideal 30 to 35 Newton centimeters of torque and be able to immediately have those implants restored with a full arch temporary acrylic prosthetic, not a final prosthetic, of course. Nasal floor piriform rim position. When you think about anatomy, the actual position of the piriform rim relative to the nasal floor is higher. So the piriform rim is the bony arch of the nasal cavity, obviously left and right side. But once we enter into the nasal cavity, the nasal floor is lower as we travel posteriorly. So when you're looking at a panoramic radiograph or even a CBCT scan panoramic view, what may look like the nasal floor may just be superimposition of the thick piriform rim, and you're not ideally seeing what the level of the nasal floor is. And that's very concerning. If you're just using 2D radiology for implant placement, when you have moderate reduction in anterior height in the maxilla and selecting the right implant length. So if there's any compromise with regards to your treatment planning, you want to switch over from a 2D to a 3D, and using 3D radiology for implant planning, I think, is ideal. Obviously, for cases that are easy and straightforward, you don't have to have the patient undergo a cone beam CT, but when there's anatomical changes and compromise, you certainly should. Vertical bone distance from the IAN canal and mental foramen. Again, any reduction in bone volume, resorption of the bone because of the patient being edentulous or partially edentulous for a period of time, you want to try to have better radiology and radiography for implant planning, and we'll talk a little bit about that. So the lingual bone fossas or concavities, as we all know, anteriorly, you have the sublingual fossa where the two sublingual glands live, and then posteriorly, below the mylohyoid line is where the submandibular fossas live. And when we're replacing a lost posterior mandibular molar dentition, we have to know what the depth of that fossa is. Perforating through that fossa with a drill, and eventually with an implant, but with a drill, could lead to severe trauma and laceration of the lingual artery, lingual nerves. A patient could have a huge hematoma in the floor of their mouth, obviously damage to the submandibular gland and other structures. So we don't want to go there. That's not good. Vestibular depth, probably less of a concern with regards to implant fixed prosthetics. However, when you have shallow vestibular depths or a reduction in vestibular depth that is iatrogenically created because of buccal advancement flaps, due to extractions leading to a potential oral antral communication, and you have to create a flange type prosthetic, locator or bar overdenture, then that vestibular depth may still be a concern. So we may need to do some pre-implant or pre-prosthetic type of vestibuloplasty procedures. But oftentimes with fixed prosthetics, that's not much of a concern. The keratinized tissue width is very important. A minimum of 1 millimeter, ideally even 1.5 to 2 millimeters of keratinized tissue around the healing abutment and eventually around the future prosthetic abutment is mandatory. It reduces the risk of peri-mucositis. You've got bound down, keratinized, attached tissue that is not mobile, that is not going to get easily inflamed, hence leading to peri-mucositis, and then of course the destructive process of peri-implantitis. So connective tissue grafting, whether it's autogenous or whether it's an allograft, is something that should be considered either pre-implant surgery So in preparation of the site, or maybe between stage 1 and stage 2, with the insertion of a healing abutment or anywhere in between. Performing that procedure later is more difficult. You may have recession, which can result in anesthetic results for the patient. Tissue biotype, tissue thickness. The better the tissue biotype, as we know, it's the more ideal scenario, especially in the aesthetic zone. When you combine thick soft tissue biotype and maybe a thinner buccal or labial cortex, you have the camouflage and the protection of not seeing the implant shadowing through the tissues. You don't want to rely on that. Ideally, it would be a good distance, 1 millimeter to 1.5 millimeters of distance from the buccal or labial cortex, and then a good soft tissue biotype, but that's not always present. And the way to achieve it would be potentially to do some connective tissue grafting to prepare the site before the implant procedure. And then upper lip length, elasticity and firmness of the upper tissues, that's really very important, especially when we're dealing with potentially having to do an all-on-4 or a full arch type of procedure on a younger patient that has a really high smile line, gummy smile, and that's going to require us to vertically reduce the alveolar bone so that the junction between the prosthetic and the actual soft and hard tissues is buried beneath the lip and not at the lip line, and of course definitely not below it. So a lot of considerations there when you think of what this patient should have prosthetically, and then which implant placement or where the implant should be placed to give them a final aesthetic prosthetic. Upper and lower lip line to the edentulous ridge, which I just mentioned here. Genial tubercle height. In atrophic mandibles, the genial tubercles, which is where the attachment or origin of the genioglossus, the tongue muscle, geniohyoid, which is the suprahyoid muscle, that's where they originate. And in severely edentulous ridges, where you only have about 1 centimeter to 1.5 centimeters of vertical height, that genial tubercle can be superior to the actual mandibular ridge. And you don't want to reduce the genial tubercle. By doing so, you are detaching those muscles, and that's actually not a good thing to do. But when the more difficult aspect of this is actually raising the flap and having the position of the implants so that the future prosthetic is not encroaching on the tongue muscles and the suprahyoid musculature as well. So a lot of planning and definitely 3D technology and radiology in that. TMD with limited opening. There's been scenarios where individuals have a patient with an ideal ridge, what I call the ridge where you can land a plane on it. So it's thick, wide ridge, a lot of distance from the vital structures, whether it's maxilla or mandible, and they're like, this is great. You know, we're missing a 2-7, we're missing a 3-7, whatever it is, most posterior tooth, but forgetting to evaluate the actual patient opening and limitations in opening, creating a surgical stent, wanting to do this as a guided procedure. With guided procedures, you have the surgical stent and you have a drill that's even more extended, about 1 centimeter longer, and then the patient only opens about 30 or 32 maybe at the incisal edge. There's no way you're going to be able to get that drill in the posterior region. You may have to freehand it by using the regular length drills or abandon that procedure. So assessing this limited opening early is crucial. The occlusal plane, obviously having a reverse curve of Spee or having combination syndrome, resulting in the tuberosities being about 1 centimeter lower, both bony and soft tissue, relative to the anterior ridge. All of that's going to play a role. And of course, how much you can reduce those tuberosities, hard and soft tissue, is going to be dependent on the position of the sinus floor. So you may be planning all of this, but unfortunately, you can't anatomically achieve that because of the limitations of the sinuses and anatomy. And then, of course, all the considerations of aesthetics, the lip line, the lip support, the condition of the natural existing teeth, the opposing dentition or opposing prosthetics, all of those have to come into play. This is a 3D screenshot from Primal Anatomy. I have a subscription to them, so I wanted to use this. I just love using the 3D anatomy when I teach anatomy to dental students, and it's a great way of learning. So we have our maxilla, of course, maxillary dentition. Here's the palate. There's your greater palatine canal with your greater palatine vessels, lesser palatine vessels to the soft palate, of course, bilaterally. Here's the lip, so that's your orbicularis oris musculature, all the levator musculature above. And then here you have your buccinator muscle, so our cheek muscle. Obviously, the mandible is cut away. We'll look at that in a minute. And then when I take away the palate, above the mid portion of the palate is where the right and left nasal cavity. Midline, of course, is the nasal septum, which is made up of the vomer posteriorly and the cartilaginous nasal septum anteriorly. And then you can see the actual width of the maxillary sinus is quite narrow at the ridge. Of course, it starts flaring a little bit more, but it's not to the midline. So when we're doing procedures that require some bone grafting and sinus augmentation, it's not necessary to elevate the Schneiderian membrane and elevate the lining of the sinus towards closer to the midline, because we're really trying to achieve bone height where the roots of those teeth used to be. So it's not important to get that volume all the way there. And the further you dissect within the sinus medially, the increased risk of actually tearing the Schneiderian membrane and then having to either patch the membrane with a collagen membrane, resorbable collagen membrane, like the Krios collagen membrane, or having to abandon the surgery. So we don't want to do that. Here's the mandible. So, of course, the tongue in place. You have your mandibular dentition. Here's the buccinator muscle. And then the buccinator muscle, as we know, attaches to the superior pharyngeal constrictor muscle, right and left side. And this is your pterygomandibular raphe. So clinically, we're using the pterygomandibular raphe, patient's right side, left side, as a soft tissue landmark. The ascending ramus of the mandible with its overlying soft tissues as a hard tissue landmark, and it's between these that we insert our anesthetic syringe, medial pterygoid muscle here, so lateral to the medial pterygoid muscle or medial to the ramus of the mandible, and then injecting the local anesthetic for an IAN nerve block. Anterior to the IAN is where your lingual nerve lives, so upon withdrawal, depositing a little bit more local anesthetic to get the lingual nerve, and then of course the buccal nerve is out here. And this is the same diagram with the tongue out of the way. And if I went back to the concept of what we were discussing about the sublingual fossa, where the sublingual glands live, right and left, this is your mylohyoid muscle. This is the deep lobe of the submandibular gland. It wraps around the posterior surface of the mylohyoid muscle bilaterally, and then part of the gland lives beneath the mandible or inferior border of the mandible, and that's known as the superficial lobe. So it literally wraps around the back edge of the mylohyoid muscle. So here anteriorly and superiorly in the floor of the mouth is where your sublingual fossas live. Posteriorly, beneath the mylohyoid ridge or line where the mylohyoid muscle originates from, is where your sublingual fossa lives. So if this patient is going to lose a 6 or a 7, we're not replacing 8s with implants. If they remove these teeth and we don't have an idea of the depth and the concavity size for the submandibular fossa or sublingual fossa, the drills could easily perforate through. Perforating through is going to damage glands, nerves, vessels, muscle. Obviously, it can be quite disastrous for the patient. So knowing the anatomy, of course, like I say, crucial. Okay. So treatment sequencing. So this is how I treatment sequence for patients. My initial consultation with the patient often is not one consult. Sometimes I have 2 or 3 consults with the patient because the first consult ends up being a prosthetic discussion. So they may have already spoken to the general dentist or the prosthodontist about prosthetics. They come to me and it's kind of like everything has just sort of disappeared. So I ask them the question, so what is the plan for the final teeth? What are your final teeth going to look like? And they kind of look at me confused. Back it up a little bit. Are they going to be coming out of your mouth? Are they removable? Or is it going to be something that's screwed in? He goes, well, or she, we've talked about both. I don't know, we haven't really decided. Can you tell me more? So now my first consult becomes a prosthetic consult, and I have models that I've purchased with Nobel Biocare. I have implant models. I have models of all on fours, locators, things like that I love using. You can also make your own models. And I demonstrate that. I also actually on my screen and my computers at the office have a PDF, non-graphic PDF of dentures, locator overdenture options, bar overdenture options, fixed prosthetic options, whether it's partial bridge work versus all on four fixed in all acrylic, also in zirconia. I have all of those, again, non-graphic slides in a PDF that I show the patients, and it's a great way to have that discussion. Sometimes that first consult has to end there. They need to go home. They need to think about it. We provide them with literature, which you can easily get from Nobel for your patients. They have great patient information packages to share. And then I set them up for a second consultation. In my practice, I don't charge the patient for a second consultation. They come in, they have a chance to review the material. Maybe they bring in their partner or their wife and husband, and we discuss surgery at that time. Obviously, before we discuss any details of surgery, I have reviewed the patient's medical history, I've reviewed their dental history, their past dental experiences, what their needs, what their wants are, and what their expectations are. And those expectations definitely need to be addressed, and we'll talk about that in a sec. Basic radiographs, I always start with a Panorex. I do not start with peri-apical radiographs or bite wings. It's a Panorex. I need the full view. That's important. And then we progress to 3D x-rays if needed. The prosthetic design is understood, finalized in conjunction and communication with my prosthetic colleagues. Then I look at the anatomical limitations. Oftentimes when we're at the surgical appointment discussion, I have a cone beam CT, let's say I'm planning an all on four. I use the DTX Studio software with the patient seated in the consult chair and start treatment planning. And with that visual, I can then describe why this patient needs a sinus lift, why we would have to angle the implant because this is where the nerve is, why I need to do block grafts or particulate grafts in order to build up the ridge. And a picture is worth 1,000 words. And I've had patients ask me for a little jump drive of that particular treatment planning, and I provide it to them, or screenshots or whatever it is, so that they can think about it further. And then, of course, the surgical plan. So again, in that initial consultation, I need to know who referred the patient, right? So what discussions they've had. Sometimes I get referrals from denturists. So the denturists obviously are referring this patient because the patient is losing their teeth or has lost their teeth. They're in dentures. They don't really like the dentures. They want to know their options. They may or may not have discussed all of those options with the patient. Oftentimes, they may have gone through the locator or bar over denture removable option for the patient. But the patient's like, wow, I could get something that stays in. I want to know about that. So then we have a further discussion. Okay. Obviously, former patients or self-referrals or referrals from other patients is that's a great. It's a great thing to happen. You want that in your practice because you've done a great job and people trust you. And then, of course, recording, documenting the patient's chief complaint. I have been expert witness on various complaints, and one of the main things that comes up often is the dentist or specialist not recording the patient's chief complaint, and then the patient coming back and say, that's not what I wanted, that's not what I asked for. So I have that in quotes in my documentation, and I really dig a bit deeper and document even further. History of patient's experience, have they had a bad experience in dentistry? When did they lose their teeth? Some of the patients I've dealt with had all of their teeth removed when they were 18 years old. They just didn't know better, or their parents couldn't afford anything else, and they're pretty traumatized by that. So we really need to kind of ease them into now a big surgical plan that may include bone grafting, hospitalization, implants, so on and so forth. So it requires a bit of hand-holding, especially with that as a background. Dental implant knowledge for the patient. I mean, what they know, what they've, of course, Dr. Google, which can be quite dangerous. They come in with these perceptions of what they think everything is like, what it should be like, and sometimes you have to walk them back from all of that and provide them with good education material. what their expectations are. That's very important because they may start off looking a certain way and wanting to look like a movie star, taking photographs and putting those into the patient's documents. Kind of going back to that, and I'm sure a lot of us have had to deal with this, where post-treatment, the patient is so particular about every little micrometer and aesthetic I don't know, unpleasantry in their mouth or what you've provided them, and then showing them what they started with, what just kind of flashing that up on the screen or having a picture there. Say, well, you remember this is where we started, this is what we discussed, and this is where you are. And a comparison of before and after sometimes brings that expectation reality back into focus. And then, of course, your own personal experience and training. I teach dentists, general dentists, implants. My advice to them is, as a teacher, it's not my role to provide, to give you limitations. It's your role to learn your own limitations. I provide you with the knowledge and the treatment options, what you can do, what you need to know to do it. And if you can't manage that, and more importantly, if you can't manage the complications, then step back and do the procedures that you're comfortable in. There's always someone out there that you can work with. You can still be a part of the treatment, and it may be the prosthetic part, which in most patients' lives is the most important part because they come to us for teeth, not implants. The medical history, obviously completion of a full medical form, whether it's electronic or paper, list of all their current medications, making sure that you know about recent surgical procedures, and any, especially in the oral cavity or in the maxillomandibular complex, any complications from that surgery, such as paresthesias that exist because of previous orthognathic surgery or wisdom tooth removal. All that must be documented, because if it's not documented preoperative to what you do, then you caused it. So that is very important. List of all their current medications and allergies, difference between allergies and sensitivities. A true allergy would be a rash, would be hives, obviously anaphylactic. A sensitivity like stomach upset, something giving, or medication giving someone a headache, you can obviously avoid that medication, but list that as a sensitivity and not an allergy. Social history, in Alberta, we deal with smokers all the time. I do place implants in smokers, but we have the discussion. You're at higher risk of implant failure. Generally, initially, it's a higher risk of poor soft tissue healing, so soft tissue surgery failure. Doing large bone graft procedures, connective tissue graft procedures on these patients is much more difficult, is a higher risk of failure, and if you can't achieve the volume gain that you're looking for, the patient may not be able to be a candidate for implant. Once they get their implants in, closer follow-up, making sure you're assessing them at the peri-mucositis stage and not letting them advance to peri-implantitis and failure. Consultation with an anesthesiologist if sedation is planned, obviously. Medical consultation if you need to have further documentation of their conditions, medical conditions. And for instance, bisphosphonates. So oral bisphosphonate use, I have placed implants with patients who are on oral bisphosphonates. I have utilized the drug holiday in discussion and consultation with the patient's physician, asking for a 3-month drug holiday preoperatively as well as one postoperatively until I am comfortable with the healing of the implant and soft tissues. So it doesn't have to be 3 months postoperatively, could even be 1 month. And if I see the healing going well, I advise the physician that they can get restart on their medications. So I do that in consultation with them. I provide them with a letter. I provide them with information about bisphosphonate-related osteonecrosis and wanting to minimize the risk for the patient. And I actually have not seen an increased risk or presentation of failure in oral bisphosphonate patients. Now, I do not place implants in patients who are on IV bisphosphonates. And then, of course, getting current labs. In Alberta, we have Connect Care as well as Net Care that we can actually, as oral maxillofacial surgeons, we have access to, because we also work in the hospital, to get patients recent labs. As a dentist or a general practitioner, you may not have access to online access to their labs, so you may have to call the lab or you may have to call the patient's physician to get that information. With regards to dental history, really compliance, reason and timeline for tooth loss, number of years they've been in removable or fixed prosthetics, number of replacement prosthetics they've had, reason for the failure of the prosthetics, all of those will give you a good idea of where the patient came from, what they're looking for, and what the potential risks of them having failures based on what you do. Getting them educated, making sure that they are aware of those risks still being a potential when it comes to implant, and maybe getting them educated to the point where they're understanding that all this time and money and everything that they've invested into it is going to be successful if they're more compliant with all of these things. If the patient needs sedation, also a number of dentists the patients have seen. I have had patients come to me for as a third, fourth, fifth consultation after seeing various other clinicians. And I want to know why. I want to know what they're looking for. I don't go into depth with regards to treatment planning. I really want to weed out what it is that they're searching for. And oftentimes those patients are not best suited for your practice, and you just refer them elsewhere. Making sure you have a good referral source, especially for cases that you need to work with someone as a team. Maybe not a single implant case on a ridge that you can land a plane on, but maybe other cases that require augmentation of soft and or hard tissues. So patients' past dental experiences, their phobias may mean that they require some sedation, repeat dental treatment due to restorative failures, just poor oral hygiene, poor compliance, timeline for a decision to pursue implant-based solutions. When did that come into mind? What was the reason? Is it because they've had friends who have experienced this and they've had, great success, so now they want this as an option, but are they still the right candidate for it based on the other factors that we've reviewed? And of course, number of consultations, we talked about that. Prosthetic options, what has been discussed with the patient, maybe narrowing down the discussion to what seems more relevant to them, because you can go on for hours having discussions with patients and they leave even more confused than when they came in. Bone grafting options do have to be discussed, and it's great, again, to have that 3D software where you're planning the implants either with the patient in place or doing the planning, having the patient come back and demonstrating it to them and describing what volume deficiency they have and what the options are for it, and we'll review a little bit of it. And then aesthetic expectations presented by the patient. So what the patient is concerned about and what realistically we could actually provide them. So a realistic timeline, a realistic outcome for the patient has to be discussed. It has to be in writing and it has to be understood by the patient. Otherwise, you don't proceed because the complications from that is much more involved in something you don't want to have to deal with. So patients' needs, wants, and expectations. The desired and expected aesthetics for a patient when they bring in a picture of a movie star and they themselves do not look like a movie star, we have to have a little discussion, right? So what are we focusing on here? Are we focusing on the look and the shape and the color of the teeth? That we can accomplish. Are we now looking for cheekbones and these big full lips? Maybe that's not going to be accomplished with what we're going to provide you from a dental implant. Maybe we need to talk about other things like fillers or Botox or whatever it is, if that's something that you have in your practice. But making sure you really kind of, again, walk them back from what their expectations are to reality. Make sure, of course, that you're addressing any concerns that they have in functionality. Financial realities, never ever presume that a patient can't afford something. That's not your place to do so. Provide them with the information, let them decide. Provide them with options. We give them a breakdown of locator versus bar versus fixed, and we have fixed pricing. As we all know, and you've probably heard before, fixed pricing helps close the deal. People like to have a number. They don't want to be nickeled and dimed. Nobody does. Wants to be nickeled and dimed for things. So make sure you have fixed pricing. And then, of course, warranty expectations. Now, I put an asterisk there. It's very important to be realistic about warranty. In my practice, the warranty comes from the fact that I deal with a company like Nobel Biocare, where if there is a loss of integration, osseointegration of the implant, if there's a fracture, if there's some sort of manufacturing defect that's involved in the implant, that implant is removed, that implant is replaced to the patient for no cost. That's in my practice. If they decide on sedation, things like that, that may be an additional cost because I have anesthesiologists that work with me. But if it's part of your practice, you might want to build that in. So patients want to have some sort of reality type of warranty. Obviously, it's not warranted for life. So basic radiography, like I mentioned, I start with a panoramic radiograph, and then based on the anatomy and what I am seeing and how I'm going to treat the patient, I may get a cone beam CT. Now, you don't need to obtain a cone beam CT for every implant case. You have to use your clinical judgment with regards to the width of the ridge, anatomical structures, and if, like I say, if you have a ridge that you can land a plane on, you don't need to necessarily have a cone beam CT. If you're concerned about vital structures, if you're concerned about the fossa, then of course you should have it. So here's an example, of course, of a standard panoramic radiograph. We see we have some reduction in vertical height in quad 1, greater in quad 2. So obviously implant placement anywhere in that posterior region is going to require a more significant sinus bone graft in quad 2 as compared to quad 1. We may not even need one, or maybe we can do an indirect. What we can't see, of course, in a panoramic view is the width of the ridge. I'll describe that in a second. Here, height of ridge relative to the superior border of the IN canal, lots of distance. And what we can't, of course, see here is the width of the ridge. So using CBCT and planning software like the DTX Studio, here I'm planning a maxillary implant. I'm placing it mid-ridge. I'm looking at it from an axial point of view. I'm also looking at it sagittally, so that, although sagittal is here, transverse view of the patient across the ridge, sagittal across the ridge, where the implant position and angulation, here I'm going to be reducing bone height, so I'm actually placing the implant where I want it to be because it would be for a future potential all-on-4, and more importantly, I need the reduction in bone height so that the junction of the future prosthetic is above the lip line when the patient is smiling. And then, of course, angulation. So I can use that. I demonstrate that to the patient. There's the maxilla. Here's the mandible. So in quad 4, position of the implant, look at that fossa, right? If you were, this is a 10 millimeter implant. If you were planning a 13 millimeter implant, you may actually perforate through that lingual cortex into the fossa. So now you can see the width of the ridge. You can see maybe superiorly there might be some threads that will need to be grafted. I harvest the bone during my osteotomy with a bone trap suction and place a cover screw and bone graft, maybe place a membrane, but all of this I can describe to the patient. And here's the same patient with those maxillary and mandibular implants with healing abutments in place. Okay. We do have discussions about prosthetics, so removable versus fixed, locator or bar. Do we need a flange? Is the flange required in the anterior because of the patient's class 3 malocclusion, lack of upper lip support? Without the flange, the patient's nose tips downward. You lose the nasolabial angle. Of course, not a very aesthetic result. And of course, the lip wrinkles or rhytids, nobody wants that, especially not women. Acrylic, zirconia, porcelain, having that discussion, opposing arch anatomy, condition of the dentition or the existing prosthetic needing to be replaced, realistic expectations aesthetically, and of course timeline as well, finances, and then I find that, especially when I'm working with patients where they're going from natural teeth to a future fixed prosthetic, having a period of time where they're wearing a removable prosthetic only makes them more appreciative of the fixed prosthetic. And oftentimes in a double arch scenario, loading one arch with a screwed in temporary fixed prosthetic, opposing a removable prosthetic, really leads them to appreciate not only the fixed prosthetic or make a decision to have the same procedure done on the opposite arch. So that all really kind of plays into the treatment planning for the patient and expectations. So the surgical plan, utilizing 3D radiography, implant software like the DTX Studio, basing the overall treatment on the prosthetic selection, always following ideal implant position guidelines, and then tweaking it based on what you can correct anatomically, augmentation, or in some cases, reduction in bone in order to bury that prosthetic implant line, allowing for adequate bone healing. So obviously that varies between men and women. Women in postmenopausal osteoporosis, you're going to have slower healing, poorer quality of bone. It's going to be age dependent, of course. Socket preservation may just take a couple of months as compared to an onlay or particulate bone graft, which could take up to 6 months. So very important. And of course, autogenous versus allograft. Angling implants so that the placement is, angled implant placement within limitations of aesthetics and function, angling implants and using angulated drills, using prefabricated surgical guides, preparing for that, especially with regards to patient opening. And then maintaining a variety of inventory. So whether you have the replaced conical connect, parallel versus tapered, active implants for bone grafted site where the bone bone quality is poor, being able to have what you need for Plan B. So what does salvage look like? This was actually an article that I saw and read from 2013 in Medical Oral Pathology Journal. The citation is right there. And I just kind of want to focus in on these two areas where they're looking at different types of Nobel implants and other implant systems and what is actually required for potentially decontaminating implants in order to have a successful long-term outcome. Sorry, that was my doggy in the back. So in order to salvage an implant, so salvage procedures require additional armamentarium. So here are some examples of additional armamentarium. You're going to have the implant driver to remove the implant. The implant driver for that particular implant system, that is if the implant is able to be reverse torqued out of the site. If the implant is osseointegrated, you're going to have to now rely on implant retrieval tools, such as this one. This one is actually an abutment and clinical screw removal tool, and this is an abutment retrieval tool through Nobel Biocare, and this is just an example of one of their prosthetic kits. In order to salvage, you're going to need additional skills, having advanced surgical skills, such as being able to do partial thickness flaps in order to perform apically positioned flaps, in order to be able to harvest connective tissue grafts from the patient's palate. If you can't do this, then you need to work with your periodontist or oral surgeon in order to get this done for your patients. You may need additional armamentarium, sorry about that, such as titanium scalers or a titanium brush. I'll show you an example of a case where I'm decontaminating the surface using a titanium brush. I don't have the scalers. And using other medicaments such as chlorhexidine, tetracycline, citric acid, hydrogen peroxide diluted in order to decontaminate the surface. Very important to have that. Some individuals want to use laser. Lasers are fine, but it's very important to know that not all lasers are alike. So certain lasers are specific for specific coating on implants. So making sure you're choosing the right laser, otherwise you're actually destroying the implant surface, and that actually is not a good thing. And what does removal look like? So if you're going to remove the implant, then you're going to have to rely on retrieval tools. This is a full set of retrieval tools, so implant retrieval tools, trephine burrs, that's available through Nobel. You may want to use these trephine burrs. You may want to use a thin fissure burr. You may, again, need to have that specific implant driver. I'm sorry that this is in the way. And you want to make sure that you're able to actually remove the implant. You might use a rongeur. You might even use a straight dental elevator in order to accomplish this. Okay. And then augmentation. What does augmentation look like? You could, during the removal procedure, anesthetizing a certain part of the oral cavity and actually harvesting bone. So this is actually harvesting bone during the osteotomy preparation using bone that's collected on the implant drill, using a implant suction device in order to harvest. Usually gives you about a half a cc or less of bone. The patient's ramus, you can get a block, corticocancellous bone block. Obviously now different surgical site. These types of blocks need to be secured with titanium bone screws. So now you need additional armamentarium like 1.5 millimeter titanium bone screws. Placing, securing bone blocks is not easy to do. So you need more advanced surgical skills to do that. The chin is also an additional site. And as you can see here, titanium bone screws to secure. And then removal procedures require additional armamentarium as well. Augmentation of the defect could be with autogenous bone graft, either intraoral sources or allograft bone. Allograft bone, I'll show you some examples of it, could be particulate, could be powder, could also be blocks, and then of course connective tissue, either autogenous or allograft. Some of the extraoral sources, just for completion's sake, also can be the tibia of the patient, so going to the tibial head. That's mostly cancellous bone, anywhere up to about 5 to 10 cc's of it, no cortical. I often use anterior hip, so it's the medial aspect of the iliac crest, and that's a good size cortical cancellous bone block that can be sectioned, can also get marrow from the actual iliac crest. I use that for reconstruction of atrophic maxillas and mandibles in the operating room. And then the posterior hip gives you even that much more bone volume. Cortical cancellous up to 30 plus cc's, depending on the literature, but generally you can see that. I'll go through a few cases here real quick. I know we're tight on time here. So here's a single implant placement with circumferential bone loss. The site we're looking at is site 4-2. So the implant was placed, good position, nice bone, doing well. The patient went away. They had their prosthetic. The patient came back to me 6 months later, and this is what we're dealing with. So now the bone level is no longer near. This is a Nobel conical connection, tapered implant, beautiful implant, but this is not a Nobel prosthetic abutment. So what went wrong here was that the patient could have been that the implant was a little too shallow, but at the original placement, it was actually placed within bone and even slightly subcrestal, but that can play a role. Using an off-label prosthetic abutment, that actually discredits the warranty for the implant, and then you end up with the patient having this huge ledge where plaque, food, debris builds up. The patient is unable to cleanse. The crown is very square. There's no good emergence. The long, flat contact areas, it's just set up to fail. Okay, so obviously this implant is not in a good situation for long-term success. This is what it looked like clinically. There was circumferential bone loss, thread exposure, that big bulky crown. So what had to happen here, the prosthetic crown would obviously with that ledge would have to be removed, and then either planning for potential salvage of the implant or removal. The patient's unable to cleanse around that implant. Here's it without the crown in place. There's not only circumferential bone loss and granulation tissue, there's also vertical bone loss on the buccal and lingual. Had there been lingual bone height, I would have been able to potentially augment this with a cover screw, bone graft, membrane. But with that vertical loss circumferentially, the success of this implant with salvage was not predictable. So what happened in this scenario is replace. So the implant needed to be replaced. Here's the picture or image of the implant replaced, either using a fissure burr, using trephine burrs like you have in the kit, debridement of the socket, careful debridement, augmentation, whether it's autogenous from a different source in the mouth or allograft, using a membrane on top and allowing for adequate healing time. So 3 to 6 months of healing time and then going back to replace the implant, which is what was done for this case. For that, so some take-home message for you. Number one would be failures can be reduced and or prevented with sound surgical and prosthetic principles. Number two, always use brand name prosthetic components. If you're going to spend the time and get a great implant product, make sure that you, your lab, your prosthetic colleagues use brand name and not off-label components. Poor implant positioning, lack of keratinized tissue, all increase the risk of peri-mucositis, which can lead to peri-implantitis and eventual implant failure. Remembering that implants are elective treatment and you don't want to take any unnecessary risk, whether it's your own surgical experience, your own limitations, know those. And of course, always, always work as a team for the best results, whether it's in consultation or whether it's actually performing procedures alongside your colleagues. Thank you very much for your attention. Now we're going to stop and address any questions with everyone. Thank you so much.
Okay, Reena. Now is the time for our Q&A portion of the webinar. So thank you very much for that informative webinar. I thought it was really thorough and excellent, and we got some really great questions. So one of the questions we received was had to do with guided versus non-guided surgery. So how often do you do your surgery guided with a surgical template versus freehand?
So the majority of my procedures are actually done freehand, except for specific cases where, and it's generally usually with partially edentulous sites, and when the actual exact position of the implant, you know, within the center of that particular abutment or crown is required, then I will use a surgical guide for the pilot drill. But when I'm doing an all-on-4, that is really kind of based more on getting the best AP spread for the implants and using visualization, anatomy, and placing the implants freehand.
Okay, great. And the other question was, do you usually plan, like even if you don't use a surgical guide, are you planning using your software and then maybe not going that extra step to fabricate the surgical guide?
Yes, absolutely. So I actually do a lot of my planning with the patient in the chair. So I have my TX Studio up, I have the patient's CBCT, and this is at the point of where we are thinking definitely about progressing to implants. I don't just get a CBCT just because. If the patient is ready and really wants to proceed, I then actually do the planning right in front. I take screenshots of each implant site, and there's multiple views. So there'll be a sagittal view, there'll be a coronal view, there'll be the dimension and length of the implant, and then just any areas where I know augmentation is required. All of that is in the patient's chart. So we have electronic medical records. And when I'm performing the surgery, those images are available for me on the computers in the OR.
Okay, so it's fair to say that you use a CBCT for pretty much all of your cases, for the majority of your cases, unless they're very straightforward, because that was one of the questions. Yeah, okay, good. The other question we had was around referrals for peri-implantitis and implant complications. Are you seeing more of those in your practice as, you know, with time? Do you get that referral from your general dentists and specialists in your community?
Yes, and actually one of the areas where I'm actually seeing more of that is patient referral from those vacation implant situations where they've gone down to Latin America. And, you know, not all cases are bad. Some cases are actually great, but the ones that are not great are actually quite disastrous. And in those cases, it's really not much of a salvage procedure. It is removal, grafting, replace.
Yeah, with those cases, what I find too, when we get those referrals, it's kind of an all or none. I mean, it's not just an isolated thing, it's across the board. And I think, would you say it's fair to say that we're seeing a lot, like more peri-implantitis and issues, complications with dental implants, you know, now at this point in your career than it was in the past? And what do you think, what would you attribute that to? Just poor planning or different, you know, fly-by-night implant companies, or what would you say?
Yeah, it's definitely multifactorial. I think that those individuals who place implants well, choose the cases well. You know, I teach an implant training program here in Alberta at the University of Alberta. And what I teach my dental colleagues and their general dentists who attend the program is, you know, pick ideal cases. Pick cases where you have good bone width, good bone height. You know, place 100 implants in those ideal scenarios instead of challenging yourself surgically. It's not my job to teach them, to limit them. It's my job to teach them their limits based on their surgical skills and experience. But I think one of the key factors there is also when we're working as teams, and sometimes it's even general dentists with general dentists, where one is the implant specialist and they're placing the implant. And then you have the general dentist thinking, well, okay, the patient's gone there and everything's taken care of there. But the surgical dentist is thinking the main dentist is following up on hygiene and follow-up, and that's not happening. So really thorough hygiene. In our practice, we use surgical toothbrushes after surgery. We provide them with either a Sonicare air flosser or a water pick. We demonstrate use. I mean, even though I'm an oral surgery practice, I don't want these implants to fail, and I do as much as I can to enforce hygiene.
Okay. And I think we'll end up with one other question, from Gunjan Goel, who asks your opinion on immediate placement versus delayed. I know that that's a a webinar in and of itself, but if you had to give kind of your top criteria for that, what would you say that would be?
Sure. So immediate dental implant placement in single rooted sites without significant buccal defects are predictable. I would recommend you submerge the implant so you have a longer proper emergence profile. I usually use about 1/3 of the implant height exposure of threads to be grafted. So implant goes in, slightly submerged, only 1/3 of the full length of the implant buccal threads, nowhere mesial distal, nowhere palatal or lingual. Cover screw, bone graft, membrane, let it heal for about 4 months, and then stage 2. If there's any more significance with regards to vertical height on the buccal, or if there's anything mesial or distal, definitely augment first and then wait for that 4 months or so and go back and place the implant.
Maybe we'll have you back for a webinar on immediate versus delayed implants. How does the audience like that? I'm sure we'll get a lot of requests for that. So with that, I think this is a perfect time to sign off. Reena, thank you so much again for giving up your time to spend with us today, and you did so last week. We truly appreciate it, and I'm sure we will see you again because your webinars are always fantastic. So thank you again on behalf of myself and the Women in Dentistry team. Thank you.
Thank you. Stay safe.
All right. So this concludes our webinar with Dr. Reena Talwar. I want to bring your attention to our upcoming webinars. We've got Dr. Nada Albatish, who's going to be talking about treatment planning in the war and dentition. We are continuing our Women in Dentistry Health and Wellness segment with Dr. Bruce Freeman, who will be doing a Zoom yoga class next Thursday. So make sure to sign up for that because spaces are absolutely limited. And finally, in a couple of weeks, we have Dr. Jessica Metcalf, who will be talking about the imposter phenomenon. For those of you who don't know what that is, tune in because you probably suffer from it. I think I do it on some capacity. So we welcome you to join that webinar and sign up online at womensdentistry.com. Follow us on Instagram, on Facebook, and we look forward to seeing you again and hopefully live and in person in the future. So thank you again for your attention today and have a great day. Bye.